Let us talk about all these morphology of the plaques that we have talked about. Now, whatever we have seen there on angiography or through imaging, everything we see should be considered as dynamic. It's not fixed, because during the procedure, anything may change. While wiring, it may change. While ballooning, it may change. The plaque may shift into a side branch or may shift distally, or the calcium may not break, or calcium may go down and cause problems. And a very important part is that there may be carinal shift. That the carina that we have, when you actually balloon it and stent it, the carina may shift and cause occlusion of the side branch. So these are all dynamic changes, and we must keep that in mind. So if there is any change during the procedure, we may have to adjust our strategy. We may have to go on plan B. So we have to have an open mind when we start a procedure. So never forget that things can change during the procedure. So whatever your plan may be, it may have to be reorganized and readjusted. So you should have a gadgetry in your cath lab for all this adjustment that may be required. Now, how do you select the strategy? Single provisional stenting or upfront two stents? Here, as I showed on these classification slide, a lot depends on the length of the disease, particularly in the side branch. If the side branch lesion is ostial, very proximal, and less than 5 millimeter length in the branch vessel, then the best strategy would be provisional strategy. But if the lesion is longer than 10 millimeter, then most likely one would require two stent technique. At the end of the day, European Bifurcation Club so far recommends provisional strategy rather than upfront two stent strategy in most of the cases. Having said that, almost 30% of our bifurcations will require two stent strategy. And when it comes to distal left main bifurcation disease, 50% or more will require two stents. So we have to keep all these things in mind. Now we come to the management of these bifurcation lesions. So today, with the present technology, everything should be based on merit, on the lesion and the requirement. But European Bifurcation Club still recommends preferably single stent. So that should be our default strategy. Now we just go and talk about what these strategies are. Here is actually sum up of everything. We have different type of technology, that is two stent technologies. Provisional, we all know, we'll talk about provisional also, but two stents, we have T-stenting, we have tap stenting, we have DK crush, we have provisional DK collot and inverted DK collot. So here is T-stenting. Now in provisional stenting, once you have deployed the stent, and if you feel that side branch is okay and it doesn't need any further workup, then you leave it there and your job is finished. But if you think the side branch is pinched or there is significant plaque shift, then you need to recross through distal strut. So once you cross, you dilate the struts, and of course, once you have opened the struts, once the vessel is open, and final kissing balloon is mandatory in all these patients. And of course, this should be followed by pot whenever. Okay. Then what do you do in provisional stenting once you decide that you need a second stent? So for second stent, again, the default strategy is either T-stenting or tap stenting. These will remain our default strategy for provisional stenting in those cases where we require a second stent. Now, when do we require second stent? If there is a significant plaque shift which does not go away with simple ballooning, that is one. And number two, while you're opening up the strut or ballooning, if there is a significant dissection, all these patients will need a second stent provisionally kept. So Here is T-stenting techniques. What we have done here is there is, as we have talked about, provisional pathway, first stent, and it is all done. You open the strut, it's gone. So with single stent, you get away with it, opening the side branch strut. So this is it. Now, if you have to go on to stenting, what do? You have to actually, step 1 for T-stenting, then you recross, you open it, balloon it. Once you have opened it like this, then you stent it like a T, and then you pull the balloon back and dilate it again at higher pressure, and of course final kissing ballooning, as I've already mentioned, and of course pot. Pot is something that should be practiced in this day and age, as we have enough evidence to suggest that this reduces MACE and improved long-term outcomes. The other technique can be used as culotte. You can do even with provisional ones, and of course here these are the problems you may encounter. What it can happen, that can be too proximal when you are T-stenting, then you have to internal crush. Of course, if it's too far, there is geographical miss. So these are the pitfalls that one may see with T-stenting. Then tap stenting is a much better technique. Here, you open up the side branch with a balloon, and of course, you have recrossed. It's a proximal rewiring here rather than distal, as we talked about. And here, what you do, you have pulled the stent in a little, open it up, pull it back, open it up at high pressure, and of course, then you do a kissing ballooning here, as we have seen, and of course, pot.